Want to learn more about substance use? Maybe it's something you're silently experiencing, or you have a loved one who needs help. Check out PsychHub's Mental Health Ally certification. We have a 1-hour course dedicated to substance use awareness that covers overdose warning signs and withdrawal, and resources to get help. It's only $15. Or you can complete the entire Mental Health Ally certification for just $99. Visit psychhub.com/learning to get started. Hi, I'm Marjorie Morrison.
And this is Patrick Kennedy.
And you are listening to the Psych Hub podcast, The Future of Mental Health. Imagine if we thought of mental health as a competitive advantage. Think about it. There are so many companies out there that want to suppress it. They have their EAP and they've checked the box and that's it. But we have to keep putting pressure on it, even though mental health is so complex. And there are organizations out there that don't care how complicated it is. They're still making it a number one priority because mental health touches everything. And they're the ones that are going to have the upper hand and shape the future. They're leaning into mental health, not shying away from it, and expanding their efforts by making significant investments in it. Take Blue Cross Blue Shield Massachusetts, for example. Their CEO, Andrew Dreyfus, is a true trailblazer. He understands that 50% of all healthcare spending is on only 5% of the population. And just because you have health insurance doesn't mean you have healthcare. Andrew is flipping the script. He's not carving out a mental health plan to address it. He's carving it in to Blue Cross Blue Shield's traditional services and addressing it head on. In today's episode, we're going to cover how investing in mental health does show a true return on investment and impact the bottom line. You'll hear the amazing work Blue Cross Blue Shield Massachusetts is doing, and I think all organizations can learn from and embody. So, Andrew, just right out of the gates, I know you're in healthcare and we're in a slice of that, which is mental health care, although we always try to look at mental health care as it's just part of healthcare. Tell us about mental health care, that journey for you and what it means to you as a CEO of one of our larger Blue plans.
Well, first, let me just say, Marjorie and Patrick, thanks for having me on. And you're doing some great work and getting the story and the message out about some of the larger issues in mental health is so important. So I'm glad you're doing that. I would say, like a lot of us, this starts at a very personal level for me. Like most people, I have had and still have mental illness in my family. And I've experienced it firsthand to watch people I love struggle, trying to get the care they need, trying to make sure they get treatments they need, trying to make sure those treatments are fairly paid for by the system. And so that's been a constant thing. And just to recognize, and it's been my own evolution of my thinking about how, as you kind of suggested, Marjorie, that this is an illness, just like many other illnesses, medical conditions that we treat very differently than we do psychiatric diagnoses or a diagnosis of substance use disorder. So it really started there. Beyond that, early in my career, my first job in life was as a journalist. I covered and was the editor of a weekly newspaper in Boston. And it so happened that there were a lot of community mental health programs there, and as well as a lot of programs for people who are homeless. And I saw how much those two issues were interwoven, and that a lot of people in homeless shelters, like the large shelter called the Pine Street Inn here in Boston, really had mental health diagnoses, and many had actually been in state mental health institutions for a number of years and had been discharged without proper follow-up and treatment. And so I saw it there. And then I went to work. I spent a period of time working in state government. And one of my first assignments was to work on some big, what were called consent decrees, where where patients and families had actually taken the state to court because our institutions, both for people with mental health and people with developmental disabilities, were not being adequately run. And so I saw right there, how much the mental health system in the 20th century had grown up around big institutions and really trying to keep people out of the community, how much we needed to bring people into the community with the right kind of services and treatment and care. And so I saw it as a family member. I saw it as from a public policy and government perspective. And so I just saw the need was so urgent that I knew wherever I worked in my life, I wanted to make sure that treatment for mental health and the needs of people with mental illness were at the forefront.
Your work in trying to tie all of those life experiences together, understanding as anyone with common sense who are looking at this problem would take away, and that is it's not one system. It's not just a healthcare issue. It's a housing issue. It's not just a housing issue. It's a criminal justice issue. It's not just a criminal justice issue, and you can keep going. How do we braid funding from those other systems so that we don't lose the most effective way to treat people, as opposed to them ending up in your emergency rooms up there, or ending up in the county local jails or state prison, or out on the street or in Pine Street Inn? When do we finally break that chasm between what insurers do and what government does to combine efforts?
Well, it's a great question, Patrick, and a huge question that we have to spend a lot of time on, and hopefully today, but as a community and as a society, when you look at some European models, you can see that they invest much more heavily in prevention and social services and support, whether it's for housing or early childhood education, some of those issues, and much less than we spend on the back end on insurance and medical care. So we have to start by trying to kind of rebalance our overall government and societal spending in those areas. I think you hit on some of the important areas that, in the community we call the so-called social determinants of health. We know that health care, meaning the delivery of healthcare services, is not the most powerful predictor of good health. It's much more, do you have adequate housing? Do you have, are you living in a safe family environment? Do you have the right educational support? Do you have the right income supports? How is our criminal justice system oriented? So I think we do have to recognize that mental health is an issue that spans all those kind of funding areas, and it has to be a much greater focus, because it'd be wonderful, and it is wonderful in the rare cases where, like within a prison or a jail system, we have a good mental health treatment program, but that is so too late. And I would actually suggest, some of what we know about childhood development is that we probably have to start there. We actually have to start. We know some early work I did in my career that in what's called infant mental health, you may be familiar with, is you actually have to start treating mental health before a child is even born. We know if a child is born in a household with domestic violence or substance use or other issues, that creates what some of the professionals call a kind of toxic stress that has a long-term impact on the mental health of people, and by the way, the physical health, because as we know, those two are intimately connected, and we almost should not talk about them separately. Some really interesting work has been done by Jack Shonkoff and his colleagues at the Harvard Child Studies Center. And so we have to intervene much earlier, Patrick, is part of your answer. And we have to kind of not see all these funding streams as separate, but we have to integrate them. And we can talk today about different ways to do that.
So it's surprising to me because, the public policy people, both on Beacon Hill and in DC and in other places, they need these solutions. I think they're more than willing to start to adopt them, but they're waiting for someone to show them the way.
Yeah.
And it's amazing to me that we don't have these economic models of, like, for example, social impact funds. Everyone complains, we can't ascribe attribution to know what the proper inference of an ROI is just because of the housing, or just because, like you said, that early intervention, how much of the differential can be ascribed to that. But I mean, that's what you've got, like these IBM Watsons and McKinseys and so forth to figure out. I mean, these are smart people. If they talk about AI, well, forget artificial intelligence. Just give us some plain intelligence to figure this out. And it seems to me we have plenty of slippage while we still can make a big difference. So we don't have to make perfect the enemy of the good, but we have to get these social impact bonds so that we can get, some of that housing fund that Governor Baker and some of this, and then get, the new president, when he's trying to put some money to the states to kind of make up for the gap on the COVID, maybe add some flexibility in those authorizations so that it can be paired, so you can get more out of what you've got. Because Massachusetts, Rhode Island, other states are going to have a huge deficit as a result of COVID. It may actually be the crisis that gives us the opportunity to repurpose some of these dollars that have been siloed in the past, but can now be put together for greater purpose.
Yeah, and you're absolutely right about that, Patrick. And I hope that COVID creates an opportunity for us to focus more on kind of holistic health in a sense of incorporating mental health into physical health. So let me tell you about a couple ways we've tried to do that in small ways that might be interesting for your listeners and for people in the public policy realm. So, after we passed universal health care in Massachusetts in 2006 and implemented in 2007, we knew that one of the first things we would have to worry about is the affordability of care and the quality of care, because it would not be that useful to just hand people an insurance card if they couldn't get good care. And what we saw was that the biggest reason that healthcare remains complex, fragmented, and expensive is that we've, for a century, been paying what we call the fee-for-service system. We pay for office visits and hospital admissions and procedures. We're not really paying for health. And the irony is, if I'm a patient and I have a chronic illness, and my physician takes such good care of me that they keep me out of the hospital, we pay less. But if they don't follow up with me and I get admitted to the hospital, they get paid more. And if while I'm in the hospital, I contract an infection that could have been prevented, they pay more again. Now, isn't that backwards? Shouldn't we be paying more for better health? So we started doing that, and we introduced something that at the time was called the alternative quality contract, that if we had known it would have had such a big impact, we would have called it something much more interesting, like Blue Sky or Blue Breakthrough or Blue Innovation. Everything's blue in our system because of the Blue Cross Blue Shield. But the program went ahead so fast and was so successful that that name stuck. And what we started doing was, rather than paying for individual procedures, we started to pay what we called a global budget for a health of a population. And so if we have a group of Blue Cross members that are going to particular physician practices, we're going to pay on a monthly basis for all their care and let them sort out how best to deliver that. And so what we saw starting to happen was, in the example that we're here to talk about in mental health, they started embedding social workers in the primary care practice, because it makes no sense for a primary care physician to see one of their patients who is in distress because of a mental health or an addiction issue, then try to refer them out somewhere, and they have no guarantee that that follow-up is going to be made, as opposed to having it integrated in the practice where both the social worker and the clinician, the medical clinician, are kind of viewing the patient holistically. So we saw some early success in that, and we required that these practices not carve out mental health or behavioral health. You've probably heard that term before, where it's dealt with by a separate. We wanted to carve it in, make it part of the traditional delivery of services. And we're doing that even more broadly now. And so we're starting to pay, Patrick, more for the care when there is that kind of coordination in the practice between social workers, psychologists, psychiatrists, and medical doctors. And we think that is building up what you're trying to get us to, I think, Patrick, which is to say, look at the health of the population, look at their housing needs, look at food insecurity, look at educational issues. I mean, we know one great predictor of pediatric health is reading ability. It's not just, are you getting all your immunizations, or are you getting your well care visits? So we are trying to do that, and that has been an exciting development.
So in Rhode Island, we had all the payers, based upon their market share in the state, contribute a capitated investment in early childhood services that none of the individual payers could justify, because the ROI was not, was too long term.
Yeah, right.
So if you look at a new funding model, that would be a great partnership with you and Governor Baker, perhaps, is to get your colleagues in Massachusetts to say, hey, listen, let's do these early child pediatric stuff. Let's address the adverse childhood experience issue. Let's put a pool of money together that we as a group now become the board of, and then choose to pay for, because it's all going to mean a healthier population and lower of a burden on us as the payers down the line, because all these kids are going to be our subscribers. And in no
Yes,
time.
no, and we've looked at that Rhode Island model, and it's some great work that was done there. One of the issues I struggle with as I think about that is what is the role of employer-sponsored insurance? Because of course we have companies paying for the care, and what is the role of our kind of public health system? And on the one hand, I really like the Rhode Island model because it's exactly as you say. There should be a return on investment because if you're investing in early education, it should cost less healthcare burden down the road. But I also don't want to take the pressure off public funding resources because as we've learned during COVID, we've underfunded our public health infrastructure severely over the past 20 or 30 years. And sadly, we're kind of paying for it now. So where is the right role for employer-sponsored insurance to pay, as in the Rhode Island model? Where is the right role for the public sector, whether it's the federal, state, or even local government to pay? Those are complicated questions to sort out. But as you say, Patrick, we kind of have to just get started and see what works and see what results we can get and evaluate them carefully so we know if this works and we can demonstrate it in Rhode Island or in Massachusetts. We could try to adopt it nationally.
So I really think the primary care for all should be our mission as a country right now.
Yep.
Medicare for all kind of got a big buzz in the last election, but explain how primary care for all could be transformative. And what I mean by primary care is, of course, what you mean, and that is integrated mental health and social services.
Yeah, I think it's so important. I mean, so much of our that what we pay for in healthcare is paid for care when I don't want to say when it's too late, but after we've already gotten complications. We know, for example, that 5% of all spending is on, 50% of all spending is on 5% of the population, and 25% of spending or so is on 1% of the population. And while there are probably a few, trauma cases and neonatal early births and stuff, the vast majority of that high spending is on people with chronic illnesses. And I include mental health in that. And usually they have 2-3 diagnoses. And we know that if you intervene early and give them the primary care in that your primary care for all model, you're going to promote better quality at lower cost, which is kind of the holy grail in healthcare. We spend probably more than we need, but we don't get the results we need. So how can we spend less and get more? It's by investing earlier in the course of illness. And the way to do that is in primary care. And for too often, we've kind of spent too much on specialty care and not enough on primary care. So you're right, Patrick. I mean, health insurance is important, and I strongly favor and always have favored universal coverage because I think you want to make sure everyone has access into the system. But what system are we giving them access to? And if it's not a system that has at its center good coordinated primary care that includes attention to developmental issues, mental health issues, and substance use disorder issues, then we're kind of not really giving people the promise of true health. So you're absolutely right on that.
Well, I hope that your leadership on that, the new president of the AHA, Rod Hochman from California and Providence, can really help push that. This is a time for us, a real opportunity with the new president and the isolation that people are feeling in this country to connect them to a new type of healthcare that really monitors kind of their chronic illnesses or really prevents those chronic illnesses from manifesting in a much more debilitating way. Can you tell us why it's taking so long? You're in an innovation hub in Massachusetts and Boston to get the interface of technology and maybe wearables and our phones and how much our phones tell us about how much we move, how much we connect with our friends and families and things of that sort to better monitor how are we in real terms. I'm surprised that the Apples of the world and these that they just haven't gotten this thing down. And I know.
Health is complex and it's quite individualized, and there are more substantial privacy safeguards that are in place in the healthcare world, as you both know. I would say that Apple, Amazon, Microsoft, Google, all are making major investments in healthcare right now. And I do think we're kind of at the cusp of much more interconnected healthcare. And there's a new federal law that's going to require healthcare entities like health plans like mine or hospitals or physician practices to exchange information much more easily. I mean, it's still very frustrating. I sometimes told the story of my father who cut his finger in doing some cooking and got taken. It was bleeding enough. He was taken by ambulance to he was going to go to the Brigham and Women's Hospital in Boston, which was his hospital, but they were on what's called diversion, meaning that they were full. And so he got sent to the Beth Israel Hospital, which is practically next door. And as soon as he got in the hospital, they started asking him all these questions about his health. And he said, well, you could just look at my record. And they said, well, we really can't because that's over the Brigham. They could, I want to say, just like lift the window up and shout out, can you send me Dr. Dreyfus's record here? The fact that two major Harvard-affiliated Boston academic medical centers couldn't exchange information, and that's gotten better since that time. But we really have a lot of work to do to make sure that healthcare, is the word we use, is interoperable. But I think to get to your underlying question, Patrick, yes, I think COVID has unleashed some new technology, which has kind of infiltrated the healthcare system in a new way. And the most obvious example is kind of what we're doing right now is kind of just online communication. In the month of February, we had about just a few thousand telemedicine before COVID started, telemedicine claims each month. And that just skyrocketed as soon as COVID happened. And suddenly people were seeing their doctors and their mental health clinicians online. And what's been fascinating, I'm sure you're tracking this, is that what stayed the strongest has been mental health visits over so-called televisits. And we announced right at the beginning that we would pay for all remote or televisits or virtual visits at the same rate we paid for office visits. Wow. Previously, they had been less expensive because it was seen as having kind of less cost involved and less overhead. And then we announced we would do that permanently for mental health visits. So we are permanently paying for telemedicine visits to a mental health clinician at the same rate we pay for office visits. And, it was interesting because the mental health professional community had been fairly resistant to telemedicine as a kind of channel or a venue to have an in-person visit because they thought it was so important to kind of pick up cues that you might only do in the office. And I think for certain conditions and for certain patients, that's still really important. But a lot of clinicians are reporting that their patients really like the model. They're never late for their visits. They're not stressed out from parking or transportation issues. They're less likely to cancel their visits. And so we've kind of seen in just a few months' time, Patrick, a kind of revolution in the care, at least of what we would consider kind of traditional outpatient psychotherapy and clinical treatment in the mental health and addiction field, which is pretty exciting. So I think it shows us that we can change, that the healthcare system, which has been so resistant to technology, can change rather rapidly on a dime in this case, and can have some permanent impacts. But again, we don't want to just feature that kind of isolated. We were talking earlier about coordinated care, and so you want to have all the clinicians involved in the patient's care. But I think we are going to see technology really change. We're also seeing, as you know, and I'm sure you may know more about it than I do, some of these kind of virtual apps in the mental health field. We work with a group called Learn to Live, which is good for kind of milder conditions, anxiety and some depression, some mood disorders. And so I'm excited about what's going to happen in the next 4 or 5 years in mental health and overall primary care virtually. I think more in-home care is going to be really exciting. We have had a kind of hospital-centric healthcare system. We have to have a patient-centric healthcare system, and that may mean caring for more people, not in the office but at home.
Well, I love that coming from a former president of the AHA in Massachusetts, that you're in it to win it. Thank you for that. It's true.
Calling all mental health providers. Looking to specialize in treating adolescents? Check out PsychHub's cognitive behavioral therapy courses. Receive specialized certifications and hone in on your skills. Get 1-year access to patient videos and worksheets that you can email or text to your clients to keep them engaged in between sessions. Plus, you'll be placed on the PsychHub registry, where consumers of mental health who are searching for certified providers that are specialized in their condition can find you. To learn more about CBT for adolescent training, visit psychup.com/learning.
Now, advanced directives.
Yes.
I want you to talk a little bit about that because, for those of us who have mental illnesses, the biggest challenge is that you lack insight when you need care, because
Yep.
if you're in the middle of your illness, you don't think you're really that bad. And, the issue of privacy is clearly very sensitive, and it should be. But if people in moments of clarity, after they've been delivered care and they're better, can make those decisions in advance, that they're willing to have, for example, this data monitored, they're willing to have a much more aggressive kind of early intervention, high risk kind of profile be applied to them so that they don't kind of veer off. That's going to require this kind of compact. And I don't think our civil legal system has been really up to the task of addressing this. When you think of the higher rates of dementia amongst our seniors, higher rates of autism and aging out of autism for the 21-year-olds and above, and those with addiction and the huge explosion of addiction, it seems to me we really need to work with our civil justice system to iron this out, to make it easier for the medical system to respond much more proactively.
Yeah, so you're onto a really important issue, Patrick. And so I would just say, even more broadly in the healthcare system, we need to do a much better job of talking with patients early on and regularly, because people's views change over time about what are their kind of beliefs, values, and preferences for the care overall. What are their beliefs, values, and preferences for the care? And we know, and there have been studies, and we help support some of these, that when a clinician asks a patient about their values, beliefs, and preferences for the care, both the clinician and the patient and the families have a better experience with their care because they're allowed to articulate it. And so it's very important for everyone to complete advanced directives, to designate a healthcare proxy, to talk with their loved ones and family members and friends and partners about what they would want for their care, and to have that conversation again and to kind of destigmatize that whole issue. I wrote a piece about my own experience with the death of both my parents and a sibling. And in each case, they had the opportunity to articulate to us and to their clinicians their preferences for the care, and they were honored. And it made such a difference at the end of their life. And each of them, struggled with different both medical issues and in some cases mental health issues. And it made a huge difference, Patrick, to clarify that and to rethink it and to talk it over. And some people want to talk it over with spiritual advisors and clergy and others. So we actually have formed a coalition in Massachusetts called the a coalition's focus on serious illness care. And we have medical groups and hospital groups and health plans and religious groups and community groups all working together to try to improve the experience for people when they have a serious illness, including mental illness, and at the end of life. We're measuring it. We're doing surveys every other year of the Massachusetts public to see how many people completed an advanced directive, designated healthcare proxy, talked to their clinician about the care, what those experiences were. We're training medical students, nursing students, social workers, how to have these conversations, because, by the way, that was not a traditional part of formal medical nursing and social work education. We're working on the technology. There's something called a MOLST system, a medical order for life-sustaining treatment, and we're funding and working with the state to put that online, so you can do that. So they didn't have to open the window at the Beth Israel and shout over to the Brigham to find out what my father's values, beliefs, and preferences were. So a lot of really interesting work is going on. And you make an important point that I'm not sure we're focusing sufficiently on, Patrick, which is that there are different and even maybe more urgent needs for people with a history of mental illness or substance use disorder. And you talked about some of the cognitive impairments that develop with aging. And it's really important that we start this early, and it's never too early. And there's a great organization in Cambridge or Boston now called the Conversation Project. They're doing some work in this area to encourage families to have this conversation. It's just so important.
I'm curious because you've been in this for so long in this space. What have you seen with mental health? I mean, from when you first started in your role to now, I mean, are you seeing that mental health is a bigger conversation? Are you seeing more claims? Can you talk a little bit about the spanning over time?
Yeah, well, so one thing, even before we get into the issue of the claims, is want to talk, because we haven't really touched on it, is on the stigma a little bit. And I do see that's still a huge issue, but it has changed over time. And I've just been struck by how deeply and kind of culturally ingrained the stigma around mental health still is. Because on the one hand, we say, as Patrick said at the start, that we should treat this like any other illness or disease and not kind of separate the brain from the rest of the body, as he said. But the stigma is insidious. It's in everywhere. And we were working on the opioid epidemic in Massachusetts and really trying to encourage people to get treatment. And I picked up my card, my Blue Cross Blue Shield of Massachusetts card, and I noticed on the back there was a line that said, for emergencies, call this. For substance abuse, call here. Substance abuse, which is back to kind of blaming the victim, and which we don't want to do, or blaming the patient. And so we're trying to change that. We're trying to, in the addiction side, we're trying to, we dropped methadone treatment, which is, widely accepted and can be successful treatment for opioid use disorder, but we would charge a copay every time someone went. And, they would have to go, every day, and that was a barrier. And so we removed that barrier. And so we're trying to really reduce barriers to care by reducing the stigma. And I'm watching that change. And I think I'm watching and I have two kids, one who's 21 and one who's 29. And I'm watching with them, they're changing views of mental health. And it's more accepted in their peer group to talk openly about it than it was certainly ever in my peer group, where if you were seeing a therapist, you were kind of almost embarrassed about it. And it just can't be the way. So I'm really seeing a lot of changes in that way.
Do you require your mental health providers provide evidence-based treatment? I guess that you have no other answer but to say yes, but we're not seeing just, from the experts nationally say that a big percentage of the providing of mental health is not based upon the evidence base. And I just personally can attest to that. I've been seeing the best psychiatrists in the world in my life. And it wasn't until I left Congress and I got actively involved in 12-step recovery that I realized none of them practice cognitive behavioral therapy.
Yeah.
The single greatest evidence-based form of treatment. And,
so that there is a huge gap there, and CBT, cognitive behavioral therapy, has a very strong evidence base. I spent some time with a leader of one of our local mental health organizations who's a psychiatrist, and he told me one of the greatest regrets in his life is treating patients with PTSD, not within a cognitive behavioral therapy framework. And he was taught actually to never ask a patient about their trauma. And he said he spent years with some patients and not really got to the root of their problem. And when he was trained in CBT, it just revolutionized the way he dealt with patients who had undergone a trauma. And so it's a challenge, Patrick, because on the one hand, we've tried to loosen, a big complaint of mental health clinicians have been, they don't want the health plan looking over their shoulder and second guessing their care. And so we've actually tried to loosen also some of the administrative burdens that clinicians face. Many mental health clinicians are still solo practitioners or in very small group practices, and they don't have the kind of administrative infrastructure of medical practices. And so we've tried to actually back off some of our administrative requirements, but at the same time trying to share some of that evidence base. And you're right, it's not, the evidence base is not disseminated in the same way it is in more traditional medical care, where people are kind of keeping up with the journals and keeping up with the evidence base. And I think you talked about the Biden administration. I hope that there can be a big investment at the federal level, because that's where the big research funding is in mental health care. And we have to kind of, we talk a lot about kind of going from the bench to the bedside in the life sciences. We need to do the same thing in mental health. We're not making that transition sufficiently.
And just to let you know a little bit about Psych Hub, that is what we do, is we train, which is probably where Patrick was going, but we do train behavioral health providers on, how to use evidence-based practices. We kind of describe it like we give oncologists new information about new chemos, not that we teach them how to do their job and then give them videos to feed back to their patients. But it is true. I mean, it's really fascinating when we see when there are providers and they are honing in their craft and they are getting, certified, which is what we do into treating anxiety or insomnia or depression or adolescence, that they give exactly what you said earlier: better care, quality care, better experience. And it saves money overall. There's an ROI because you're getting more precision therapy, but it is a movement that has to happen.
One organization that, if you don't know about, you might want to take a look at, that just started, is called Brightline. And it's a new group. It's a new kind of mental health practice that's starting in the Bay Area. And I'm pleased to say that their second location is going to be in Massachusetts, in the Boston area. We've invested in them. And it's a group of psychiatrists and social workers and technology experts, Patrick, who have been successful in some other areas, who have come together to try to establish a new kind of practice where they will have occupational therapists, and they will work with families, and they will work with schools. That's one of the things. Families, especially families with kids with mental health problems, just have such a kind of time, a bewildering time, trying to navigate. What are they doing in the school? What are they doing? What is the pediatrician's involvement? What is the prescriber, the therapist, OT, PT, all these different disciplines? They're going to bring them all together under one roof, and work with families and with schools, with kids, starting with younger kids, but going up over time. And we're excited about those, and they're going to be transparent with measurement, using some of the screening tools and measurement tools. And the parents can actually view them. They could view them over time. What is my kid's PHQ-9 today? What was it last month? What is it going to be next month? And so we are trying to invest in some of these evidence-based models.
My wife's a public school teacher, and it's shocking to me that we don't have greater integration with the schools.
Right.
She'll tell you the 30% of her kids that she just knows intuitively are coming from ACE backgrounds, where their families are stressed from poverty and domestic violence, mental illness, and there's nothing she can do. It's just, I would hope, when you go back to your earlier point about getting the employers to think of how they can be part of this, we have to introduce this new processing model of how do people think and manage stress. Because this is important for kids to navigate the new worlds of huge stress and cyberbullying and everything else, combined with the fact that they don't have those resilience skills because now they're so plugged into technology. They don't have the real world face-to-face socialization that, kids of an earlier generation got. And then, of course, they're going to go in a very challenging world. I would think that there's some kind of model in social emotional learning in schools, but just translating into maybe employee assistance program for businesses and within the health insurance system, all to build your resiliency. So the anecdote I use here is the Green Berets really work on their mental health. And I say to myself, why do the Green Berets? They're the toughest bunch in the whole crowd. And it's because they know that through practice and drills, they can prepare themselves for the most onerous situations that they can be placed into. And if the military has figured this out, why hasn't corporate America?
Yeah.
Why haven't the insurers? And most importantly, why haven't schools figured out that if a kid can't manage their stress and their amygdala is off the charts, they're not able to focus on their numeracy and literacy.
Yeah.
So it's kind of like pre-cognitive behavioral therapy, or if you will, CBT applied to before I get into trouble.
Yeah. Well, it's interesting what you said about employers. So obviously, our company, Blue Cross Blue Shield of Massachusetts, as soon as COVID happened, we went to fully remote, and we fortunately had the technology systems to support that. But there was a lot of stress obviously among our own workforce. And we have several really skilled psychiatrists led by Ken Duckworth, who's our top psychiatrist and also works with the National Alliance of Mentally Ill. And he offered and his colleague an online session on mental health. We thought, maybe 30 or 40 people would show up. Hundreds upon hundreds of our workers showed up for it. And now we're doing it regularly. And it was so successful, we offered it to some of our employer customers who absolutely realize now, in a way I think they may not have before, how important it is to help manage stress in the workplace. And then we started talking about like parenting, like how could we support our own employees in their own parenting, because they had kids at home who had questions about COVID, were out of school, online learning. And so I think the employer location is a very good venue for that. And I know there are some other companies, again, some on the West Coast like Lyra Health, who are really trying to work with employers in new ways. And so we shouldn't ignore them. It's an important locus of activity.
Yeah, but the EAPs is still minuscule.
I think we have to go well beyond that. And we're relooking at that for our own employees. But again, we were fortunate to have our own kind of mental health team right there in house that could kind of support some of our workers.
I appreciate that you've done so much, that you prioritize it. It sounds like you've really made mental health a priority with all of your initiatives.
Well, it too often, and I don't really understand that with some of our other companies or competitors. Most companies, as I say, they carve out mental health. They say, we're going to hire a third party to deal with it. We carved it in. We want to say, this is part of our core capabilities of what we can do for our members and our customers. And then once we saw it, we said, well, we know people aren't using it enough. We know that people who have a medical diagnosis and a psychiatric diagnosis consume more medical care. In other words, they're going to spend more. If you have depression and an oncology cancer diagnosis, you're going to spend more money on the oncology side. So we know there's actually, back to your question about a return on investment, there is an ROI, Patrick, by investing in mental health services. We realize that it's the right thing to do for our members. We can't continue to stigmatize mental health, to stigmatize a substance use disorder. We have to bring it into the mainstream, and we have to model that behavior ourselves, and we're willing to invest in it. I mean, we just saw that there was still a remaining big shortage of child psychiatrists. Massachusetts, not a shortage of actual child psychiatrists, but child psychiatrists that would accept insurance like Blue Cross. And so we took a hard look at that. We significantly increased our reimbursement for child psychiatry. Happily, some child psychiatrists.
Thank you for doing that. Yeah, that sent ripples across the country. You did a great job with that.
And so we just want to say, this is a valued service. This is a valued service. This is essential to overall health. And we're going to keep experimenting with reimbursement, with payment models, with partnering with groups like Brightline or Learn to Live or others. Until we can do this better. And it's not, unfortunately, we're not going to be able to do it in a month or a year. We have to keep at it. But it's just such an important part. And if we can decrease the stigma, more and more people come forward, which I think is happening, I think will long term. And then we start to look at the social determinants of health that we started with. We'll have a healthier population. And by the way, we'll be a better company for it. And some people are actually employers are going to come to Blue Cross because we provide better mental health care for their employees. I mean, isn't that, we want to have a competitive advantage because we provide better mental health and services for addiction for our members. So we see it as not something to avoid or to hide, but something to value and elevate.
Well, 2 points on the systems change, not just with the kids, and there were kids who are being boarded in your ERs and everywhere in the country because there's lack of referral services, but also those with SMI or people who come in with self-harm. We need a much better HEDIS standards to really ensure that there is the proper discharge planning and safety assessment. And I think that just, come back, we'll make an appointment in a week, which is what the current HEDIS standards are, and we'll see if you follow up. Given the rate of increase on suicide, the tragedies of that, we really, I think the AHA, and I've spoken to Rod and Rick and others, we need to ramp up with the new administration a much stronger emergency response in that space. Because like other challenges, CBT works in that area too. Right. The evidence base says you can actually, people say, well, you could never, how could you ever predict someone's going to have? Well, anybody who's tried is going to, likelihood is trying it again. Right. You can get rid of those thoughts that that's your solution for your problems through active CBT, but that's never the discharge planning. So what we'd like to see is a bright line for that.
Right. Well, that's interesting. Using the measurement system in HEDIS as another kind of sphere of influence to change the patterns of care makes total sense. That's certainly what's happened in diabetes and in kind of heart disease and other areas where the kind of using quality measures that are based on evidence have actually changed the processes and outcomes of care. We should do that in mental health as well. You're absolutely right.
But it's not in the EMR. That's the big systems change we need to make.
Absolutely.
Well, we know we've really taxed your time today and given you plenty to think about. So we're so grateful for your generosity in spending this much time with us.
Thank you, Patrick, for all you've personally done to advance the field. And thank you, Marjorie, both of you, for this program, which is kind of just elevating the dialogue on mental health. We need to do that. Keep it up. And we just need more voices kind of pushing the nation to kind of deal with the mental health as an urgent problem in a way that we haven't in the past. So thank you.
We're grateful for you. It all adds up as we have these conversations. It's going to take everybody leaning in on it. So thank you.
Absolutely. Okay.
Thanks for your time.
Be well and be safe. Okay.
All right. Really appreciate it.
Yeah.
Take care.
Okay. Take care. Bye-bye.
What's cracking, Hope Nation? It's your friendly neighborhood Kevin Hines. And here is your brain health tip of the week. Be hopeful. Holding out hope or having hope gives us a shining light no matter the personal circumstance or struggle. It's all about perspective. Even in our darkest days, and those days for when you're not feeling so hopeful, make sure you have a safety plan in place. If you want to learn more about suicide prevention and how to develop a safety plan, check out PsychHub's Mental Health Ally certification and visit psychhub.com/learning.
As always, thank you for listening to our podcast.
If you enjoyed the show, drop us a review.
If you haven't already, subscribe to our podcast for the latest episodes.
For the latest insights, check us out at psychhub.com.
Calling all mental health providers. Looking to specialize in treating adolescents? Check out PsychHub's cognitive behavioral therapy courses. Receive specialized certifications and hone in on your skills. Get 1-year access to patient videos and worksheets that you can email or text to your clients to keep them engaged in between sessions. Plus, you'll be placed on the PsychHub registry, where consumers of mental health who are searching for certified providers that are specialized in their condition can find you. To learn more about CBT for adolescent training, visit psychhub.com/learning.